Dirk did med school in his native Germany in Berlin, and then residency in Montefiore and a renal fellowship at the Brigham, where he worked on zebrafish physiology, which I think prepared him for the mechanical and technical challenges of being an interventional nephrologist. And he transitioned to doing interventional nephrology in the mid 2000s. And we've seen our use of interventional nephrology and the procedures per year go at a steady upward rate ever since, particularly with the training and recruitment of Dr. Wojciechowski. He's well known within access issues. And I can say personally, he's elevated my own access evaluation, although I don't usually get it completely right when I send him patients. But without further ado, he's going to be talking about dialysis vascular access assessment and complications.
Thank you, David, for this very kind introduction. My disclosures and the objectives to dive into dialysis access, stimulate you to kind of incorporate this into your own practice. And I'm fully aware that I'm between you and the end of the course after a long and intense week of listening and learning. So we'll dive right in. What do you think this upper arm access has as a typical stenosis? And the options are juxtaanastomotic, needle cannulation segment, cephalic arch, and arterial anastomosis. If you want to kind of use your voting pads, count to 10 silently. All right, there's some timidity in terms of voting. There's some votes there. Perfect. And so this is an upper arm brachial artery to cephalic vein fistula. The most common hemodynamically relevant stenosis will be found in the cephalic arch. And you have here an angiogram where you can see the brachial artery at the bottom, and then you see a relative narrow spot in the juxtaanastomotic segment. But it turns out that even with narrowing down to 3 or 4 millimeter, flows up to 2000 are still possible. So the key issue is really looking at the outflow vein issues. There's some valves in the middle, and then you have that cephalic arch that here in an early point of time in this axis does not raise its head yet. But over time, you can see here that this axis has undergone multiple angioplasties of the outflow, and then eventually even had some stents and stent grafts placed, multiple thrombectomy episodes. And in the end, you can see that the body of the axis where the needles go in has these nice cannulation segments, and you can see that the juxtaanastomotic segment now even really has a 2 or 3 millimeter stenosis, which gives the axis about 1,000 ml per minute flow, and managing the outflow in this type of axis is really the key. Now, learning about other typical sites of stenosis and accesses will help you focus your attention to them. So here are the 4 common accesses listed: radiocephalic, brachycephalic, transposed brachybacillic, and prosthetic graft. And then 4 sites. The freebie here is the cephalic arch. Please find what combination of stenosis do you think is the one that is fitting. What is the most common stenosis that's relevant hemodynamically in a radiocephalic forearm fistula, in a transposed upper arm brachybacillic vein fistula, and what is the most common site of stenosis in a prosthetic access? No matter what kind of prosthetic you use, if it's PTFE, if it's a biograft, if it's one of the new kids on the block, there's a thing called Symves, which is made out of human cells and grown in the lab. and has particular antibiotic resistance. There are newer products also with bioabsorbable molecules that are mounted on stents. All these things kind of are in the production line now. I see a lot of votes there. And yes, indeed, option C is the correct answer, as almost everyone kind of put out there. The location of stenosis in fistulas, in the forearm, the relevant stenosis are over 50% and above, either at the anastomosis or immediately in that inflow segment. However, in the upper arm cephalic vein, it's usually the cephalic arch, over 55%, and only a minority of cases is the juxtanastomotic segment, the inflow side, relevant. Treatment, we have learned that in the upper arm, in managing cephalic arch stenosis, stent grafts are superior to just angioplasty. And there are newer technologies out there for juxta-anastomotic stenoses, may it be in the upper arm or in the forearm access, external support devices, either made out of nitinol, nickel titanium alloys that kind of expand, or absorbable, and they provide stabilization as an external scaffold and seem to reduce endothelial hyperplasia. The use of drug-coated balloons in this context and management of stenosis is, as of now, really in the air. There's no clear data one way or the other. In grafts, it's very clear it's the venous anastomosis and the immediate outflow vein segment that is in most cases the issue. There have been 2 randomized controlled trials looking at the effect of stent grafts in this segment, and that is typically very successful and can then lead to interprocedural intervals of between 6 and 18 months, depending on other patient factors. So that's a very effective way to treat these type of stenoses. Overall, in the management of dialysis access, you have what is called chronic access disease, or I call it that way. And it's basically pre-programmed sites of stenosis that are specific to the type of access, and you've learned about some of them. Venous anastomosis in a graft, cephalic arch, the swing point in a transposed upper arm fistula where the vein is moved around and potentially torqued. Sites of site branches that often are associated with a valve, and the juxtanastomotic segment. On top of this, you have then the fact that the flow in an access is increased almost 100-fold in many cases, and the shear stress becomes very different and induces endothelial proliferation. There may be episodes of thrombus exposure which lead to a biological pathway of involution and scarring. There may be stenosis that recur after angioplasty as a result of just a balloon injury, or just the recurrent stenosis of scar formation. If we use stent grafts, then those, because they're stiffer than normal vessels, they induce new places of irregular flow that then are associated with debris formation, causing stenosis on their own time period or timer. And then there is needle insertion that both can have an effect through focal thinning of this entry site, as well as repeated vessel wall injury at the needle tip site. So there are lots of things that cause chronic access disease. And there's really no access that is completely stable over years and years and years. Here's an example of, again, a right upper arm access. I showed you that initial photo. You're familiar with it already. That within kind of a relatively short time and then over the years develops larger and larger needle insertion site aneurysms. So what is the force, or why is it that dialysis accesses transform like this? And here you have the question, 5 factors that may or may not have an influence. What do you think is the dominant, like the most important and possibly also, influenceable factors in this? And so please take a look at the options that are available. We have, outflow stenosis, which we learned are very recurrent. Focal needle insertion sites, which may thin the skin as each needle site heals, basically. And if there is pressurization at the needle site or in the access, you will then have kind of an outgrowth as the healing is under pressure, and each time the living, breathing vessel wall and the living, breathing skin add cell layers to it. High inflow, gender and genetics of people, race and age. So do we have any takers there? I can see the votes coming in. And so what I think is, and what the community thinks of people taking care of dialysis access, is really the combination of three things: recurrent outflow stenosis, the amount of flow volume that goes in, as depending on the outflow stenosis, with higher flow, you have higher intra-access pressures, and focal needle insertion that then predisposes to this outward remodeling of the needle insertion sites. So here's some more information. You can see that this access started out with like 2 liters flow, was banded a couple times to reduce the flow, had stents and stent grafts placed in the outflow to moderate that. But then if you look in the right lower corner, you can see that before and after angioplasty, the measured pressure in the access, right, is not quite as high as the mean pressure in the artery, but you can see that it goes up to 64, comes down to 49. We've done studies in accesses that feel nice and soft, like the perfect pressures, and it's about 25 to 35 millimeter mercury is the intra-access pressure of an access that really feels, by physical exam, in balance and has very minimal or very slow formation of aneurysms. Here's an example just to make this a little bit more pregnant in your mind. So this is a upper arm non-transposed brachybacillic fistula that is in use. And you can see kind of how it nicely collapses if the axis is open, right? You can see here, though, in the angiogram that this axis has a recurrent outflow stenosis, in which context these aneurysms have developed. You can see the needle insertion sites are enlarged. When you measure the flow volume, it's about 1.3 liters at high blood pressure, and the intra-access pressure approaches the mean arterial pressure, 92, which is really high. That's like a very, respectable systemic mean arterial pressure, and that's the force that is enlarging the axis. Now, if you treat that, try in your mind to predict what's going to happen to flow volume and what's going to happen to pressure. I'll give you 3 seconds to think. And so what happens is, in this case, that the axis feels softer. The flow actually does not increase significantly, and that's because of that little blue arrow that you see. There is a flow regulating inflow stenosis that, depending on what the blood pressure is, only allows for minimal increase in flow, and most of the time the flow is about a liter or 1.3 liters because the artery is pretty large. At the same time, though, with the access open, the intra-access pressure goes down into that range, 25 to 35 millimeter mercury, that is associated with very little enlargement of aneurysms. And so in the end, we place a stent graft across this for long-term patency, and with that amount of flow, these stent grafts can be very, very effective. So what you want to take the take-home message is here: you can control flow with an inflow stenosis, and you may do that intentionally, like banding, and intra-access pressure will rise significantly with these recurrent stenosis, and these episodes of long elevated pressure lead to aneurysms. Now, here a quick example of an access that's been used for several years that has an inflow stenosis, also upper arm. You can see no aneurysms, right? It presents because the unit has difficulty placing needles, and you see the black and blue there, because the access flow is so low now with the recurrent inflow stenosis that the access cannot augment anymore. So they basically have a flaccid vessel that they're trying to put a needle in. And you can see here the intra-access pressures before and after angioplasty, and they maintain or they stay within the normal range, but post-angioplasty, you have access flows that go from 300 to 800, and so you stop recirculation and you allow sufficient augmentation with that amount of flow. Move on to the next case. Here is a left upper arm brachiocephalic fistula that was created when the patient had an eGFR of less than 20, as the guidelines recommended. And she hangs out for 7 years before she actually needs dialysis, but presents basically around that time when she initiates with shortness of breath, bleeding after needle removal, and she has a left numb hand and it's occasionally painful. She kind of has had this for a little bit. And so the question is, what is going on? So here are her symptoms: shortness of breath, bleeding after needle removal, initiation after a long period of time, hanging out in advanced CKD for many, many years. So what of these conditions do you think might be present? Is it some kind of heart failure thing? Is it, cardiorenal syndrome? Is it deposition disease with where somebody really fought starting dialysis for years and years and years? Or is this the consequence of a high flow dialysis access that's been present for a long time? And the questions that are coming in are all kind of, the votes are coming in, and it's mostly, so the right answer is that in this case, the unifying answer is it's a high flow access. And I'll just go through some of the findings that you can have in this case. So flows were measured 2.5 liters, okay? But, and the concept here that I want you to take home, and this is probably one of the key concepts that I think people need to realize, is that there's a dose of dialysis access that goes on top of everything else that's going on with your patient. So you have an age-dependent decline in cardiac output reserve, right? And the average age of a dialysis patient is 67 years when they initiate. And so a lot of people are on that right side of the curve. They have limited reserve. So if you dial in this enormous amount of like a high flow of an access, you will get cardiac symptoms. And they may include, in the end, pulmonary hypertension, LV dilatation, decrease in EF. And on the access side, if you have long-standing high flow in an upper arm brachiocephalic vein fistula, that cephalic arch eventually will narrow down, and the axillary vein to subclavian vein transition, the bottom of that reverse T there, where you can see this narrowing, that is a sign of years and years of high flow pounding that venous wall, and you get endothelial proliferation, and you get narrowing there. So her flow with that stenosis in place is 2.5 liters. So if we treat that stenosis, her flow is likely to increase significantly. So now you look on the other side, on the inflow side, you can see on the right-hand side the connection between the cephalic vein and the brachial artery, and the cephalic vein is humongous, right immediately after the connection with the artery. There is no break there. Like you saw in the picture before with the little blue arrow, that was a 2-3 millimeter stenosis. Here, it's just wide open. So now you have a 6-7 millimeter artery that basically is delivering unlimited flow. And the only thing that keeps this flow from going higher is the stenosis and the outflow, right? But as a consequence, the access is so pressurized with a massive inflow, limited outflow, that you have bleeding after needle removal, and you can't really use this access well. In addition, if you look at the hand or the outflow on the right-hand side, there's very little blood going towards the hand, which gives her the numbness and the occasional pain in the hand, and that is called steel. That can be treated with banding, right? So if I occlude the access, you can see, yes, the arteries are there, there's just no blood going there. So this patient needed an angioplasty and then of the outflow, but at the same time, immediately after, or very soon after, a banding procedure so that the flow could be effectively reduced. And I'll show a little bit more about this. So, in this example, we had a high flow access with steel. Now here's an access that is more normal in terms of flow, 1.4 liters, which is kind of right about what an upper arm access usually has. 1.2, 1.4 is kind of a very good target range. The goal from the Society of Interventional Nephrology is to have access flows of less than 1.5 liters. That's plenty for the machine, and it's probably as low as we can be, or as high as we can be without putting too much burden on the heart of most of these patients. And this patient then presents with these punctate necrotic lesions on his finger. When you do an angiogram in this patient, you have the same phenomenon. There's no blood going to the hand angiographically, only with occlusion of the access is there flow to the hand. Now, why does this patient have this with relatively modest flow? Well, it's a typical dialysis patient with diabetes, hypertension, peripheral vascular disease, coronary artery disease, and so steal is a very common phenomenon there. The treatment there is that one creates a stenosis right at the anastomosis. So in this case, two bands of about 3 millimeter were created in this fistula, and then all of a sudden there is antegrade flow in the towards the hand that then perfuses the hand sufficiently, and these punctate lesions can heal while maintaining access flows, in the 500 to 700 range, which is sufficient for dialysis. The technique of banding, is that you kind of really put a suture around it. We use proline sutures, not silk sutures or nylon sutures, as those can have been seen to cut through the tissue, but this is from the original publication. Then our center has done a study looking at over 400 banding procedures, and the most common reason in our clinical setting is actually banding before major complications develop. So this is when you have high flow, when you start to get enlargement of needle insertion sites, when you see the writing on the wall, because once you get into the situation that you have heart failure, that you have aneurysms with thin skin, it becomes much more difficult to surgically revise this and restitute good function. So to just drive this point home about aneurysm flow and physical exam, here we have two accesses. One created in 2008 that has undergone a series of interposition grafts because you have a wearing out of the original conduits. While on the right-hand side, you have a fistula that has been continuously used for 20 plus years and has, slightly enlarged needle sites, but the skin is completely intact, gentle depigmentation in some places, is used in self-cannulation, so very meticulous rotation of spots. So when you think of the physical exam, how are they different? Left, scabbing and repeated revisions. Right, everything looks beautiful. Here are the things to consider, 5 factors. Pulsatility, there should be a pulse as long as the patient is alive. There should be there's a thrill at any transition of high to low pressure, so physiologically at anastomosis, and also then pathophysiologically at any site of stenosis, right? Pulsatility will be increased if the blood comes in and there's an outflow stenosis, right? A flow murmur typically has 2 things to consider: the pitch, continuous or discontinuous. The augmentation is basically how much an access will how strong it will pulse when you occlude it completely. So if you have an inflow stenosis that's very severe, then even with complete occlusion, the access will only have a very mild pulse. A very high flow access without inflow stenosis will have very strong pulsatility and very strong augmentation. And then you have the collapse against gravity, which is basically a balance measurement for what is the capacity of the inflow in relation to how much blood comes in. So the combination now. So the question is, which of the answers is the correct one? And on the left, you have the axis with scabs. So pulsatility is increased, and there's an outflow thrill because there's a recurrent outflow stenosis that then leads to these recurrent episodes of skin breakdown, aneurysm formation that then leads to repeated need for surgical revision. We'll go through these a little bit more in detail. So here, this is a video of pulsatility. You can see a forearm loop biograft, that is, they are jumping in your face, and this is because there's a high-grade venous anastomotic stenosis, and every time that the heart beats, the axis beats. When you can see pulsation in the axis, you know there's kind of a mismatch between how much is coming in and how much can go out. Now, this is a upper arm brachiocephalic vein fistula that doesn't seem to have matured. There's increased pulsatility only at the anastomosis. There's a thrill kind of along that scar. When you occlude the axis, very little augmentation. And now listen to this flow murmur. So you can hear that there's a discontinuous component. There's a very strong component systolically, and then almost a pause diastolically. And that's kind of concerning. When you have a discontinuous flow murmur, that means there's a critical stenosis somewhere in the axis. And you can hear it usually at the site of the stenosis. If you go post-stenotic, you have a lower amplitude but possibly continuous flow murmur. So here's the angiogram that corresponds to it. You can see flow was measured as less than 400. There are two stenoses right in the juxta-anastomotic segment, right after the anastomosis. Cephalic vein is relatively small. This is about 2 months after access creation. This is what you hear again, you know, the flow murmur. When you treat this stenosis, you can see that within less than 4 weeks, you can measure like a tripling almost of the flow volume. The vein diameter, as basically part of the shear stress induced vein dilation, goes up, and this is how it sounds. It's like ocean waves, continuously undulating. Okay, so this is kind of where, when you go through your units and you listen to the fistulas, practice it so you will very easily pick this up. Just want to go back to the augmentation. So if you have a new fistula and people struggle to cannulate it, especially if it's a forearm fistula, then you may have difficulty with augmentation, either because the inflow is low or because you have side branches and the segment just does not augment well because you have deep collaterals that cannot be augmented. And so the concept is a little bit like a cup that you try to put a pen through, right? If you stick it where the side is open, it compresses the vessel, and when you finally have enough force to put the needle through, you may go through and through, and you get infiltrations. If you have sufficient augmentation, then the vessel is firm, like on the bottom side of the cup, and if you push through, you'll actually get into the lumen, and you'll not penetrate all the way. That's kind of what I would keep in mind as a concept. So, you know, how does that look in practice? Here's an access with relatively low flow because the patient has chronically low blood pressure in the setting of systemic amyloidosis. And in order to create a access that then was supposed to be used in the home dialysis setting, a really focused vessel was needed, and all opportunities for blood to dissipate had to be taken away, right? And so the side branches were marked, and then the surgeon kind of ligated side branch 1, 2, 3 and left number 4, right? Because we want multiplication of outflow at the elbow to just keep the pressure low. And so you can see after side branch ligation, and then a month later, you can already see that the vein really has nicely matured, even though there's only 400 flow, but this access was then used for several years successfully in the home setting with minimal interventions. If you, this is an example now of inflow-outflow balance. Again, an axe that's been used for many, many years, 15 years, without really focal aneurysm development. And that's in part because when you kind of leave the arm down, you see this distension. When the arm is lifted up, you can see collapse completely. So there's very good inflow-outflow balance with minimal extra force that leads to external remodeling. And so, on the left, increased pulsatility, throw in the outflow for recurrent stenosis. There's probably a good amount of inflow in an access like this, and there may be a discontinuous flow murmur. And then in the graft and in the pressurized fistula before it was replaced, there was really no collapse. While on the left, you have normal pulsatility, you have a thrill at the inflow side only, and afterwards the pressure is very soft. You have only moderate augmentation, and you may have complete collapse in this upper arm access when you lift the arm. All right, question 6. What kind of fistula is this? You just have to believe me, this is a fistula. And there's some options here. This may be a traumatic fistula, after forearm fracture. It's actually not a fistula, trick question. This is somebody who's just exercising a ton. Or this may be an ultrasound-guided fistula, or it was created with ultrasound guidance. Or it's the collaboration of gifted plastic and vascular surgeons, and you can't really see where they even made an incision. The first responses are in. The only responses I see is option C. And it is true, you probably all have heard about this. There are now endovascular fistulas that are being created. And, one of the challenges is it's really a revolutionary concept. And all of a sudden you have people that don't use knives, non-surgeons, create fistulas very successfully based on the proximity of the proximal radial artery and the deep communicans vein. And so what you rely on then is that the blood from that connection goes into the cephalic vein in the upper arm and not into the brachial or basilic veins in the upper arm, so that you can cannulate and dialyze. There are different anatomic types that predispose or that work better with this. Some don't work at all because they don't have a cephalic vein. But what you often find angiographically is this. You basically see a convoluted nest of, one artery, which is kind of the darkest vessel that is kind of seen on the left, but that's then has two other additional vessels on top and the bottom. Those are the brachial veins. You have the cephalic vein on top, but then you also have veins that go to the forearm, and the blood goes anywhere, and that's very difficult to navigate procedurally, and it's a setup for failed cannulation. And so, in our local center, what we do here, we just put a stent graft there. And then we direct the flow right into the cephalic vein. We shut off all the deep collaterals. And that has been our strategy to make these work. And there are new generations of this type of fistula that are in the works that use similar principles of initially placing a stent graft. There are endo AVFs now at the wrist that are being trialed. So there's a lot of work in this after having clinically established that the principle, making kind of a fistula over a guide wire with a needle puncture from a vein into the artery. After this principle has been established as being successful, now we just have to figure out when do we really use this in the best possible way. In your clinical practice, a key is that you find a surgeon that has interest in dialysis access, as surgeons that do more fistulas seem to have more success. And so, the thing is that in the United States, you have about 4,000 surgeons billing fistula creation codes. That's a ton of surgeons. And there are about 80 to 100,000 fistulas created each year. Or 60,000 in the Medicare base. So it's, I think, 80,000 to 90,000 if you count all fistulas. But the success of fistula surgery varies if you sort it by surgeons depending on how many fistulas they create. And so you can see that the high volume surgeons have success rates between 65 and 85%, right? While the bottom surgeons in this analysis have success rates of 23%. And nationwide, the fistula success rate stubbornly still sits at only 59%. So it's almost a 50-50 chance you go to surgery and your fistula is not going to work. And this is despite the fact that in the US, 75% of fistulas are created in the upper arm, where the veins and arteries are big already, right? Other countries have a much stronger focus on forearm fistulas. Our local experience is that we create 70% of fistulas in the forearm, 90% coming off the forearm radial artery, and we have success rates of 80 to 90%, tweaking all aspects of the fistula creation process. Close follow-up, endovascular, like we're doing venograms instead of ultrasounds, a lot of things. You can do this, and the surgeons with a lot of success and with high volume, they probably also have process of care issues that help them. So you need to work with surgeons, and it has to be kind of a team. There has to be endo support. There has to be experience from the HD unit that goes back to the surgeon so that they can continuously learn. Now, in the last 10 minutes or 8 minutes, I want to focus a little bit on what we don't really want long-term, what we cannot live without, which is tunnel dialysis catheters. So here are 4 patients that each have an issue, and you let me know which issue or which picture shows which issue. So there's one exposed cuff, there's one tunnel infection, one exit site infection, and one catheter that was placed by somebody who usually doesn't place tunneled catheters. So here's the combo questions that you can get. So see what you think. What's the exposed cuff? Which one is the exit site infection? Which one is a tunnel infection? And then which one is an unusually placed tunneled catheter? We'll give it a few more seconds here. Multiple colors at the moment. I like it. All right. So my official answer is C. Okay. And I'll run through all options. So this here is an exit site infection. So you see basically the cuff is kind of where the little arrow is, and the cuff is a barrier between the sterile tunnel and the vascular system and the colonized segment between the cuff and the skin. So if the cuff is all the way up because somebody shoved in that catheter to the hub, there will be colonization 2 centimeters into that tunnel, right? Symptoms are itching, discharge, drainage. You can treat these very successfully, 70-80% of the time with IV antibiotics. This here is a little different. This is kind of this patient presents with a change in mental status. There's tenderness along the tunnel, like where the clavicle is, and you may appreciate the erythema that is along the tunnel. And so if you now massage that tunnel towards the exit side, you can often, because the cuff is not sealing effectively anymore between exit site and tunnel, you can often put the pus out. That's an empyema, basically, in a preformed space, and there's not much you can do but to take it out. Yeah. Here, you have an exposed cuff, and there's often itching, there's often a little redness, there may be an early infection. This is a situation where you want to give empiric antibiotics, and then potentially you can still save the vessel access site by exchanging the catheter and retunneling it laterally or medially off the current site. And then this is an unfortunate gentleman who was at a hospital where there was a very willing and dedicated surgeon to provide access for him, but he just didn't know how to place a catheter, and so did a cut down on the subclavian vein and made an incision in the skin to then retrograde, kind of put the catheter in and then close the incision through which he laid the catheter. Now, it turned out that despite the cut down, the catheter was not intravascular, and it did miss every major structure, but it was actually in the mediastinum. And after a CT and careful assessment that it's not going through any large vessel, this was removed and a new catheter was placed in a different site. Other unfriendly things that tunneled catheters do. Here is a gentleman with a tunneled catheter. You can see, the tip location, and what is the consequence of having a catheter tip in this location. And this is something that every nephrologist should kind of do usually. So if you have a tip kind of in this location, right, what are possibly associated with this? Catheter dysfunction, central vein stenosis, infection, dialysis access, arm edema if you have a fistula created on the same side, fib and sheath formation. And I'll give you some options here. And in case you haven't realized it yet, I'll almost always go for C. But so it's catheter dysfunction, central vein stenosis, and if you create an access, you'll get arm edema. So what you really want is you want the tip about 5 to 6 centimeters distal of the carina. That is the right atrium, and that is where the tip of the catheter should be to allow for very high flow, 450 in, 450 out. So there's like 800 to 900 ml of blood flowing, and you need a big space to take care of that. If your tip is kind of in the brachiocephalic vein, which is there, then you may get this. This is the same patient, and you can see exactly where the catheter tip was, right? Pounding that wall, sucking on that wall. You develop a long-grade stenosis with massive arm edema that needed to be treated. And you can see that, with colored dye that comes out of these catheters. And depending on what kind of tip you have, you kind of see it jets into the wall or it goes straight down. And depending on if you run them reverse, you can also see how the different catheters, split tip or on the right symmetric tip, behave. And symmetric tip is kind of the standard of best flow distribution that we can envision. The fib and sheath, here's a catheter where we were able to pull it out pretty long, and you can see that the fib and sheath basically hangs around the catheter, and as the catheter tip moves in and out, depending on if the patient sits up or lies down, that tip pulls into the fib and sheath, or the fib and sheath goes over the tip, and then you have flow impairment. You can then angiographically, you can see this, you can dilate or disrupt the fib and sheath so that you can then get back to a patent vessel and you place your catheter in there, and you get better catheter function. Cumulative exposure to tunneled catheters will over time narrow down the vein lumen, and if you have a cardiac rhythm device in there, it will further compound the narrowness and then predisposes to central vein stenosis, both on the left and on the right. I mentioned the cuff position. So here's a left-sided tunneled catheter, and the cuff is placed with the patient lying down. If there's sufficient chest tissue, then the patient sits up, and then the catheter may actually reposition itself. And in this case, you can see it kind of got pulled back and is just firmly set against the wall. One word about catheter exchanges. If you do a guide wire exchange with disruption of the fibrinous sheath, you get about the same overall clearance of bacteria as if you remove it and do a delayed reinsertion. This patient with a tunneled infection, you will see that when you pull out the catheter, you can see that there's debris, pus, in the fibrin sheath. So we have started to disrupt these after aspirating the purulent material. And so here are some take-home messages that I really want you to kind of focus on and maybe remember. So that access flow obviously has to be sufficient for dialysis, but limiting access flow is important to preserve cardiac function and prevent steal. Intra-access pressures are elevated before access flow falls significantly. So you may have there are lots of machines that monitor the access flow, but the pressure is elevated and you get aneurysm formation and skin thinning. A forearm access on average has lower flow because of a lower artery and is preferred. Tunneled catheter tip position is key to function, and you want to be able to just do a check on the chest x-ray to see that the tip is in the right position. Thank you very much for your attention, and there are some references and clinical trials for your own perusal. Thank you very much.